So thank you for joining our webinar today about diabetic foot health. Our webinars are designed to provide caregivers with information they can use to keep themselves and their loved ones happy and at home. Our expert today is Dr. Alan Bass, a board-certified podiatrist and a certified professional coder. He is also a fellow of the American Academy of Podiatric Practice Management, AAPM, in addition to serving on the board of trustees. He is also the CEO of Gerald Medical Management Consulting, providing business and practice management services for private practices. He's a frequent lecturer nationwide in the area of medical and business management. Dr. Bass has been practicing in New Jersey for more than 25 years and is past president of the New Jersey Podiatric Medical Society and currently serves as an adjunct professor in the biology department, teaching medical terminology and health at Kean University in Union, New Jersey. If you have any questions or concerns you'd like Dr. Bass to address, please use the chat box, which I'll be monitoring, or raise your hand. We like this to be a conversation between all of the participants. And now I'm going to hand it over to Dr. Bass.
Thanks so much, Vicki. Well, I appreciate anybody who's tuned in today or who's listening to this recording in the future. You know, I'm very passionate about education and teaching not only patients, but also caregivers, because it's so important for everything that we do in medicine for it to be a team approach more than anything else. I tell my patients all the time that we have to work as a team in order to keep everything healthy. So, and diabetes is just one disease that patients have such a huge control over. One of the things that I tell my patients all the time, that diabetes, second only to trauma, diabetes is the leading cause of amputation of the lower legs. I always tell my patients, it's so important for you to examine your feet and look at what's going on, because we don't want you, you know, I always joke with my patients and I try to communicate this to my patients. You came into this world with 2 feet, we want to send you out when the time is right with 2 feet. We don't want any other disease to cause you to lose your feet or a portion of your leg. And diabetes, unfortunately, is a leading cause of amputation. So what are some of the causes that can lead to amputation of the lower extremity, of the lower leg, of the foot, a portion of the foot? Peripheral arterial disease. Well, peripheral arterial disease is also known, you may see it known as PAD, when the blood vessels in your legs are narrowed, usually by fatty deposits. The fatty deposits, people have increasing cholesterol. Those are a lot of the causes that people get these narrowing of the blood vessels. And what happens is blood flow to the feet, to the lower legs decreases, and you end up with pain. You know, so many times people will think about this pain that they may have in their feet or their lower legs as muscular, as, you know, overuse, or I walk too much. But a lot of times it could be PAD. And why the pain happens is because with the narrowing of the blood vessels, blood can't flow and provide oxygen to the muscles. So that's why you end up with the pain, and it's not that muscular type pain. So it's not an overuse or an injury, but more for PAD. If you've got PAD, your risk for heart attack, stroke, and amputation go up. And about 1/3 of people with diabetes over the age of 50 have PAD. But so many people don't know it. So many people don't have their lower legs or their feet checked. So many people will go to their doctor and they'll never, you know, I tell patients, if you go to your doctor and they don't ask you to take your shoes off, that's a mistake. Doctors should be looking at a person's legs. They should be looking at their feet. They should be looking at their ankles. All of these different things are indicators of peripheral arterial disease. If you've got diabetes, your much more likely to have PAD and be at that higher risk of having a heart attack or having a stroke. But you can definitely cut those chances by taking care of your health. So I always tell my patients, checking the blood sugar, maintaining your blood pressure. These are all things that go hand in hand when it comes to your overall health, when it comes to cardiovascular health, when it comes to PAD. All these things all go hand in hand.
Now, is the PAD similar to, you know, how people think, oh, they've got a blocked artery in their neck or whatever? Is this the similar thing just in the lower extremities?
That's a great question, Vicki. Yeah, so that's what it is. The PAD, peripheral, think of the word peripheral, meaning an extremity of the legs. And although you have, different, you have arms and legs, peripheral arterial disease will occur more in the legs, and it will also mainly occur, most of the time will occur in the not just in, when I say the legs, in the lower leg below the knee. So you'll have these constrictions or these narrowing of the blood vessels in the lower legs. Just like, unfortunately, I spoke to a patient this week whose wife had quadruple bypass surgery and had a blockage of the coronary and the heart vessels. They're the same type of blockages. So while these will occur much more in the lower extremity.
Mm-hmm.
Now, there's definitely certain risk factors that somebody needs to take into account. Smoking. I will tell you, I ride my patients like there is no tomorrow when it comes to smoking. That is something that I'm speechless when it comes to smoking still. In today's day and age, when people know the health risks, smoking, cutting out smoking was definitely something that will help, which is a major risk factor for PAD. Patients who have high blood pressure, patients who have abnormal cholesterol, anybody who already has heart disease. So these patients who are already being treated by their physician for any one of these three diseases, high blood pressure, or it could be known as hypertension, high cholesterol and any type of heart disease. These things are putting you at those risk factors for the problems with circulation to the lower extremity. If you don't, if the cholesterol levels are up and constricting the blood vessels, if you already have heart disease where it's not pumping good enough, these are things that can lead to PAD. So making sure you have your feet and your legs checked on a periodic basis if these things are going on is very, very important.
Yeah, and I can see the circulation issues because the glucose in the blood makes the blood like sticky, like syrup.
Right.
So you already have circulatory issues.
Exactly. So we need to make certain that these issues are checked on a periodic basis, not just when something goes wrong. I can't begin to tell you how many times we hear patients who have, I've heard stories of patients who don't have these things checked and only go to the doctor and go to the podiatrist when things go wrong, when they have a symptom. Well, if you already have other things going on, it's so important to make sure you have them checked out on a periodic basis. Other risk factors, if you've already had a heart attack or stroke. If you're overweight, weight plays a huge factor in PAD, not only in other things that can go wrong, but being overweight is a huge risk factor for diabetes and for PAD. If you're not physically active, listen, physically active means a lot of things to people. I don't care if you go to a boot camp class on a daily basis if you're over 50 like I do, or if you just go out and take a walk every day. You need to do something. I don't care what it is. Be active on a daily basis because the movement, the contracture of the muscles of the lower legs help to contract against vessels, help to push blood along, will definitely help to decrease the risks of PAD. as I said, being over 50. I mean, I'm 55, so it's time, you know, these are things that I think about on a daily basis, just making sure that I stay active and I eat healthy and I'm not overweight. These are things that I need to do in order to prevent PAD. Am I lucky that I don't have any family history of PAD, heart disease, heart attack, strokes? Yes, I'm very lucky that I don't have a family history of that. That doesn't preclude me from worrying about PAD. That's just an additional thought that somebody should have, that if a mother or a father or if a sibling has these problems, they should definitely consider it something that they need to look into to prevent PAD and how it affects diabetes. So what are some of the warning signs for PAD? So we talked about that earlier. Pain in your legs that occur while you walk, but disappears after a few minutes. Well, in that same respect, so people can get pain and then it goes away. But then another thing that can happen is if you walk a certain distance and that same distance causes you to have pain. Like if you were able to measure it and say, I could only walk a quarter of a block before my legs and feet hurt, that's also a sign. So it could be one of the two things. You could have pain that goes away and you could think it's more muscular, or you have pain after a specific amount of time. Those are two separate issues, but both are signs of PAD. If you've got tiredness or cramping in your legs, remember, we talked about it earlier. That's because the blood vessels are more narrow. It is not getting the oxygen to the muscles, and the muscles you're getting that pain and cramping and tired feeling in your legs. Numbness, tingling, or coldness in your feet. Coldness because the blood vessels are being constricted. Your feet are getting colder. You could have cold feet in the winter. You could have cold feet in the summer. These are all can be signs and symptoms of circulatory issues. Sores or infections that don't heal. Sores, if you end up with a bad sore or an ulcer, if these things don't heal, that's a problem. Sores and ulcers need blood to heal. If you don't have circulation, that sore won't heal. Dry or cracked skin on your feet. Again, blood is not getting there. It's not being hydrated with oxygen and all the nutrients. That's why it's drying out. Pain in your feet or toes, even while you're resting. You do not have to be doing anything. If you are just resting and you end up with pain, that can also be a sign of PAD. So how is it diagnosed? Well, you come to the podiatrist, and what do? I check the pulses in your feet. It's how is blood flowing to your feet. You actually have two pulses that we check. You have a pulse on the top of the foot, and you also have a pulse to the inside behind your ankle that we check. If we can't feel those things well, we will also do a test known as an ABI, or an ankle brachial index. And we use an ultrasound. So a lot of times, these small portable types of ultrasounds can be done, these small probes that can emit the waves and that can tell the blood pressure or the flow from your foot and ankle. And what we do when testing the ankle brachial index, ankle meaning the legs, the brachial meaning the upper arm, we check the blood pressure as it pertains from the ankle to the upper extremity. And there's a number that tells us how is that blood flow. And it's a small number. So if you have an ankle brachial index of 1 or greater, that's good. Anything below 1, 0.9, getting below 0.9, 0.8, 0.7, when you compare those two numbers, the blood pressure to the arm, from the arm to the blood pressure to the ankle, if that number gets to be below 1, if the doctor tells you that number is below 1, that's a problem for PAD that needs further testing. They should be doing an ABI if you're over 50 and have diabetes. That's a given, no matter what. If you have any signs of PAD, no matter how old you are, or if you are less than 50 and have risk factors. And we talked about that earlier. Heart disease, smoking, stroke, family history. Those are things that you should be checking depending on family history. So it's based on age and risk factors and signs and symptoms. So it's not just one thing or another. You can't just say, oh, I'm younger than 50, I don't have to worry about it. Well, that's why we question, what's the history? Your parents alive? What did they pass from if they're not? These are things that we need to look into. What's some of the other things we do? Something known as a contrast angiography. That's more than what we do in the office. That's if we suspect PAD, we will send you to a vascular physician, a vascular doctor, somebody who works on blood vessels. You could also be sent to a radiology center to be seen by what we call an interventional radiologist, where that they inject a dye into the blood vessels, and then they will take x-rays to see how the blood flow is and where or if there is a narrowing or blockage of the artery. We said when we talked about an ABI, we talked about doing an ultrasound test. The sound waves that are emitted by the probe and how it sounds with the circulation on the blood vessels. Something known as an MRA or a CTA. These are definitely much more specialized scans that are done to see if there are some blockages in the vessels. How's it treated? So now we know the signs and symptoms. We know some of the tests. Well, how is it treated? If there is a narrowing of the vessel, something you may have heard the term an angioplasty or a balloon angioplasty, where they not only snake a tube into the blood vessel, they will then also most likely put in a stent. A stent is a small wire tube that actually is left there to keep the vessel open, because a lot of times when that blood vessel gets constricted, the body needs help to keep it open again. So we need to keep that stent there to keep that blood vessel from narrowing. A lot of times, if the angioplasty is done, if the tube is placed and then a stent isn't placed there in the blockage or in the narrowing, the blood vessel can become narrowing again. So they'll have a stent to put in. If they can't do that, if the blood vessel is too narrowed for too long a distance, they may do a bypass where another blood vessel is taken from another part of the body, and the bad or the constricted blood vessel is now taken out, and the healthy blood vessel is put in its place. What else can you do? Well, as I said earlier, I'm a huge proponent of yelling at my patients about smoking. You got to stop. If you have a family member still smoke, got to stop. You got to think about quitting. Something called your hemoglobin A1C. So the hemoglobin A1C. So a lot of times diabetics will take a daily blood glucose, and we always try to shoot for that. The numbers here, the glucose they say is less than 150. No, for me, it's about every day being less than 120. A lot of these numbers come from the American Diabetes Association. I'm a big fan of keeping, blood glucose under 120 on a daily basis. But the hemoglobin A1C is a number that is a blood test. So it's not done daily where you do a finger stick. It's something where you go to the doctor, they do a blood draw, and they look at your blood sugar over a history, over 2 to 3 months. And you want that number to definitely be below 7. I'm a big fan of getting it under 6.5. What's so interesting with patients who don't really understand their diabetes, and this is where I joke with some of my patients, and I ask my patients, well, how has your blood sugar been? You finger stick? Oh, yes, I finger stick every day. It's been 110, 120, it's been 90. It's been great. I've been keeping it in line. And then I ask them, well, how's your hemoglobin A1C been doing? Well, that number's real low, doc. That's probably, I think the last time it was real low has been about a 9. So that's pretty low. And those are patients who truly don't understand. And I try to educate my patients because they don't know that the hemoglobin A1C really needs to be below 7, below 6. Then they know they're really controlling their diabetes. Because if somebody says to me, my blood sugar has been really good, and then I ask them to send me the blood work or have their doctor send me the blood work, and their A1C is 8, well, then I know that they're lying to me about their daily blood glucose, because their hemoglobin A1C can't lie. They could try to fudge their results on the daily basis. You can't lie about your hemoglobin A1C. We talked earlier about keeping that blood pressure down. If you have you see your physician, take your medication if you have high blood pressure. Should you be taking an aspirin or a statin for cholesterol? Definitely. I am a huge proponent of talking about nutrition, making smart choices, making sure you have a healthy balance of carbs, of proteins, of fats on a daily basis. It's not cutting something out. And I was talking to a patient last night who said to me, well, I'm on a diet now and I've stopped eating carbohydrates. Well, it's not a realistic thing because you're not going to stop eating carbohydrates the rest of your life. It's about eating those carbohydrates in moderation and having the right amount of carbohydrates and fat and proteins every single day. What did I say about being active? That's really what it's about. I don't care what it is. Go for a walk. You know, we're all crazy now with COVID. Get out of the house. Just go for a walk around your neighborhood, whether it's by yourself. Say hello to your neighbor, wave to your neighbor, walk with a spouse, a friend. Could always socially distance. Get out there and walk 5 days a week. It's very, very important. I tell my patients, check your feet every day, especially if you're diabetic. Check your feet every single day. If you can't see your feet, get somebody to look. Get a long-handled mirror if you can't see the bottom of those feet. Check for red spots, cuts, sores, swelling, blisters, anything that just doesn't look right. You should be contacting your doctor. Okay? Use that mirror. Friend, spouse, I don't care. You're not asking them to touch your feet. Just let them look. Because seeing something, just visually seeing something, you will be able to prevent any continued problems if you look at your feet every day.
Okay, Dr.
Wash your
Bass,
feet. Yes.
can I interject? Mary had a question. So Mary, if you want to unmute, I saw you raise your hand. Did you have a question for Dr. Bass? Oh, no, that was a false. Okay, I see that.
Got it. Not a problem. Wash your feet every day. Warm soap, mild water. Don't soak, because soaking can actually dry out the skin and lead to cracking. Also, when you do wash your feet every day, dry between your toes. Because athlete's foot, you know, fungus likes moisture. So soaking those feet, it's great to soak your feet for a little bit. Wash them. Keep them hydrated, but dry between those toes. Fungus likes hot, wet, moist places. Athlete's foot is from a fungus. Dry between those toes. Keep that. That is not a place where you should be letting stay moist. Using a moisturizing lotion, a water-based moisturizing lotion. Like I just said, it's good to put it on the feet, but not between the toes. Between the toes is moist enough. So just, you know, use it on your feet. You don't need a lot, just need enough to coat those feet and give it a nice layer of moisturizing lotion. And when it comes to moisturizing lotion, a water-based moisturizing lotion. The first ingredient of your moisturizer should be water. It shouldn't be Vaseline. It shouldn't be A&D ointment. It shouldn't be cocoa butter. It shouldn't be baby oil. It should be water or purified water. Your body is made of water. If your skin is dry, you need to hydrate your skin. Think, you know, using other things that are Vaseline based or ointment based, it's like trying to mix oil and water. It just won't work. It's just going to put a barrier. It's not going to hydrate. Another thing that patients who are diabetic have to worry about is something known as diabetic neuropathy. Neuropathy can be something known as a burning, tingling, or numbing feeling of the feet. It's a problem with the nerves. Now, the thing is, neuropathy can be burning, tingling, painful, but it can also be where you just don't feel. So it could be one way or the other. So it can be painful, but it also can be non-painful. Sometimes patients always describe to me, I feel like they have their socks are on and they're bunching up under their feet, underneath the ball of the foot, when they're really not there. Your nerves help to control the temperature in your body. So your feet can feel hot, they can feel cold. That's coming from diabetic neuropathy. And with this numbing feeling, so if you can't feel, you might not feel a sore. You might not feel an ulcer. You might not feel if you stepped on a tack. You might not feel if you had a pebble in your shoe every day, all day long, and it's rubbing. That's because you have neuropathy. So it's very, very important for you to look at your feet every single day.
So what causes neuropathy?
Just going to get to that right before I got here. So neuropathy, the main cause for neuropathy is the increases and decreases in blood sugar. I tell my patients it's that yo-yoing, that up and down that they get from their blood sugar that causes a damage to the nerves that causes neuropathy. So maintaining that blood sugar at a normal level is so vitally important. So that would be right here, keeping your blood sugar levels that are at a manageable level. Okay, so as they go up, they damage the nerve. Okay, that's what's happening to the nerves by having that blood sugar at 140, 150, having an A1C at 8, 9, 10, and I've seen that in patients. Those are patients who suffer from neuropathy. And when you bring those blood sugars back down, a lot of times the signs and symptoms of neuropathy will decrease, will get better. They might not have as much burning or tingling, might not be as painful. They may feel the feet a little bit better. So bringing that blood sugar down correlates to a decrease in the neuropathy.
Now, can you get the neuropathy in your other extremities, like your hands?
You can. So neuropathy a lot of times comes in what we call a stocking and glove distribution. So stocking meaning feet, glove meaning hands. So I always ask my patients, do you have any tingling in the feet or numbing in the hand, in that? And even a lot of times before I ask them, do you get it in your hands? They'll say, no, but sometimes, I have trouble feeling in this finger some of the times. And that can be the start of diabetic neuropathy in the hands. So stockings and gloves can be definitely the two places that you get this. You really don't get neuropathy in other areas other than the extremities. And those risk factors that we talked about earlier, being overweight, being over 40, high cholesterol, high blood pressure, these are things that also will lead to diabetic neuropathy, as opposed to also just, leading to diabetes itself. So how's it diagnosed? Going in for a foot exam. Go to your podiatrist for a foot exam. It's very, very simple. I do some very, very simple tests to see if a patient has neuropathy. I will use, and we're going to cover it, I think, on the next slide, and I won't say it yet. So, and like I said a few slides back, even if you're not going to your podiatrist, if it's your regular physician, whoever it might be, take off your shoes and socks. Let them look at your feet. Very, very important. So how do they do it? So, like I said, go to the podiatrist at least once a year. A lot of times, based on the signs and symptoms that you have and the findings that we come up with, will determine how often you're back to see us. So how do I do it? So I test neuropathy by checking with the sensation of a tuning fork. I use a tuning fork and I bang it. You all probably know what a tuning fork is, and I place it along a bony prominence, usually on the side of the foot. And I ask them, when does the vibration stop? And depending on when they stop feeling it, because I'm still holding it and I can feel it, if it's still pretty strong in my fingers and they can't feel it, that's one indication they have some neuropathy. If it's almost done vibrating, that's a good thing. Touching your foot with something called a monofilament. It's a small little piece of, almost looks like stiff fishing wire, or from a hairbrush. A lot of times it doesn't even have to do that. A lot of times I'll just use, I have Q-tips that have like a wooden stick, and I'll break the Q-tip, and the stick will have a sharp end of the wood, and just touching them to see if they can tell the difference. I might use the sharp end, and then I might use the cushiony end of the Q-tip to see if they can tell the difference between sharp and dull. Also, I'll ask and I'll do that with their eyes closed so they can't cheat, of course. And then also using a piece of gauze, making sure that they can feel very lightly. I say, close your eyes. I'm going to touch you somewhere with this piece of gauze or with this cotton ball. And I want you to tell me, where do you feel me touching you, if anywhere? Well, if they tell you can feel it and where it is, that's a good thing. If they can't, that's another sign that they're suffering from diabetic neuropathy.
Okay. Couple questions came in. Jennifer, did that answer your question about your testing for sensation? Let me know. Just say yes or no in the chat, or if you need some more information. And then someone wanted to know, do the shoes they wear play a part in neuropathy?
Well, a lot of times shoes really don't play a factor, because while shoes may cause some numbing feeling to the feet, a lot of times when the shoes come off, so if the shoes are ill-fitting, they'll end up with something called neuropraxia. Neuropraxia is more like a compression where you don't get a feeling in a certain nerve in your foot. So for instance, or you know how if you're laying on the couch and you might have your legs crossed or your feet up on the coffee table, and then all of a sudden you can't feel, that's more of a neuropraxia, because you've compressed the nerve, and once you release that, the nerve will allow you to, that removing, stopping crossing your legs or taking your foot off the coffee table, then the foot will stop being compressed and you'll start to feel again. With this, it's really more from the glucose that's causing the patient to have the neuropathy. So making sure you control those blood glucose levels, it's so important, more than anything else. And people, they get depressed when they start having these other things that go on with diabetes. It's bad enough they have diabetes. Well, now they end up with neuropathy, or they end up with a sore. I try to stress to my patients, controlling the blood sugar is paramount. If you keep that blood sugar controlled, it will keep that numbing feeling down. That's the most important thing. Diabetes is a disease that so many patients can help control. There are medications that doctors can ultimately use if the neuropathy is not just numbing, but is more painful. It could be some over-the-counter medications. There are different vitamins that have been shown to work very well in the treatment of peripheral neuropathy and diabetic neuropathy. Like I said, keep your feet hydrated. Water-based lotion, cream, I don't care what it is. Top, bottom of your feet, and not between the toes. Every single day. Okay? A lot of times people ask me, should I wear socks? You don't have to wear socks. You should be careful if you put it on your feet and the bottom of your feet and then go walk on a slippery tile floor. I don't want you getting hurt. But keeping a sock on is definitely not something that needs to be done. And I would say just enough is the same as, is actually better than too much. You don't have to throw on a big glob of lotion. A nice thin coat, rub it in well, is so important.
Okay, before we get into toenails, one more neuropathy question.
Sure.
Can diabetic neuropathy cause muscle spasm?
Not really. More likely the muscle spasm has to do more with the PAD. Because think about, the muscle is not working or functioning well because it does. Muscle spasms a lot of times happen for two reasons. It can be from getting a cramp from doing some activity. But as we said earlier, it's that cramping or muscle spasm by not having enough oxygen. Having the oxygen and having enough blood flow will keep things from, quote, cramping. Remember how we talked earlier about if you walk a certain distance and then it starts to hurt, the muscles start to hurt or they start to cramp, and you have to sit down after walking a quarter of a block or a half a block. That's more the PAD and the circulation than anything else, but not for the neuropathy. Hope that answers the question.
I think it does.
Diabetes and toenails. If you don't have any signs or symptoms that really go against you, can you trim your toenails? Sure. As soon as you start to develop any symptoms that prevent you from taking care of your own feet by yourself, you should be seeing a podiatrist. Trim the nail straight across. I always tell people, don't go down the sides. Straight across, not down the edges. It's very easy to cause yourself to get an ingrown toenail that way. Okay? Cut the nails across, use an emery board or a file. That's it. Shoes and socks at all times. Never be barefoot. Okay? Why? If you have some signs or symptoms of neuropathy, if you're walking barefoot, let's say somebody dropped a glass the night before, you might not feel a piece of glass. You should never be walking outside without shoes. You can't, a lot of times with the neuropathy, you can't tell the difference. Remember, your feet can feel cold, your feet can feel hot. You sometimes can't feel temperature. You walk out on the pavement, on your driveway, out on your porch. You might not feel how hot it is. The summertime at the beach, I cannot begin to tell you how many patients who have diabetes who walk on the sand who end up with blisters on their feet because they can't feel it. It's so important, always wearing some type of a shoe in the summertime. I don't care what it is. Never go barefoot. And again, check inside. You don't know if you had a pebble in there. You don't know if you had a tap coming through the bottom. Check those feet. Check those shoes every single day. You can't feel the temperature, just like you don't want to walk on hot pavement. You got to be careful if you're taking a bath. Okay? Test the water before, just like if you were giving a bath to a baby. You know, I always tell patients, use your elbow down in the water. Something else. Don't just jump in. You can't tell if that water was too hot. Don't use anything that you cannot control, especially can't control the temperature. Heating pads, electric blankets, hot water bottles. You can't know because of neuropathy, or you won't know if the temperature is too hot and that you will end up with blisters or sores on the bottom of the feet. So what are some of the simple things you can do? Keep your blood flowing. When sitting, pick your feet up and down, wiggle your toes, move your ankles, okay? Don't cross your legs. You know, these are things that, you know, I even tell patients who might have problems with circulation and or diabetes, if they're going on an airplane, you've always heard, you know, stand up, wiggle your feet. Those things, the movement of the muscles help to control and compress the blood vessels and move things along, okay? If you're getting some swelling to the lower legs, if the socks are too tight, you're going to see the impression of that. You'll know that the elastic is too tight. Can't say it again. Can't say it enough. Be active. Don't smoke. And I'll say it again. Don't smoke. And Vicky, if I didn't say it yet, don't smoke. Other things, we talked about it. Sores, ulcers, blisters, ingrown toenails, corns and calluses. Let's talk about that for a second. A callus or a corn forms because the body is actually pretty smart. It forms because of friction, whether it's something on the top of the toes or whether it's a callus on the bottom of the foot. That's because of friction and there's too much rubbing. So the body's smart. It builds up tissue to prevent a sore from happening. If you have that, that means there's pressure in that area and the skin should be trimmed and taken care of. Now, you should not be doing that yourself. If you are a diabetic, you should never be, you should never be trimming or cutting calluses themselves. You should never, ever be using any of the over-the-counter medications you find to treat corns and calluses. You should always be seeing your podiatrist. Be careful if you have a plantar wart. Wow, that's a virus that needs to be treated as well. We talked earlier about athlete's foot, the cracking of the skin, the peeling of the skin, the cracking between the toes. These are things that you should be seeing your podiatrist for. Anything where you have an increase in warmth, an increase in temperature, these are things that you should be looking to your podiatrist for. And there we go. I want to thank you so much. Go ahead.
One more question. Another question came in. What is your opinion on shoes designed for diabetics?
So yes, so the Center for Medicare Services, the federal government, is actually pretty smart. They've come to the conclusion that they want to prevent certain problems. So diabetics, unfortunately, do get sores and ulcers, which lead to amputations and other problems. And sometimes, where do we find it starting? We find it starting in ill-fitting shoes. So shoes that are made specifically for diabetics, first of all, have gone through a very rigorous process to be approved by the government in order to be paid for by Medicare to wear to prevent other complications. If you've had certain things that have gone wrong throughout the years, you've had sores, you've had a digit amputated. You're the person who should definitely be using a diabetic shoe, because the shoe and the inserts that come with that are made for the shoes by the podiatrist are used to prevent certain complications. So yes, you should be, if you have any signs or symptoms of diabetes, you have peripheral arterial disease that's caused a sore, you have neuropathy where you can't feel. These shoes are made in order to prevent other complications. So that is something you should be speaking with your doctor with, you should be speaking with your podiatrist about, in order to see if you should be using and qualify for the use of these shoes by Medicare.
Okay. Any other last minute questions or concerns for Dr. Bass? I know there was a lot of great information given today, a lot to unpack. The webinar was recorded. It will be posted on the Assisting Hands Monmouth website, so you can review it and go back and re-listen. And okay, both say thank you very much.
Well, thanks so much for joining us, and Vicki, thanks for having me. And if
oh, my pleasure. Thank you for giving so much great information.
there's anything else I can do, please feel free to reach out. If you get anybody who reaches out to you, please send them my way.
Absolutely. Absolutely.
Well, thanks so much for having me today.
Thank you. Thanks so much.
All right. Have a great rest of your day.
You too. Bye-bye.
Bye-bye.